Hello, we're back again today. Lecture number 46. This is all on the biology of mood disorders, and kind of breaking this up into two different areas. We'll be talking a little bit more generally about depression in terms of some of the more conventional drug treatments that have been used. And then what we'll be doing in lecture number 47 is we'll be discussing alternative treatments for depression. And again, there's some really good videos that I want you to watch that are listed on the syllabus. I want you to look at those, and you should actually look at those before you take a look at this lecture. And of course, take a look at those thought questions and make sure that you read those thought questions and have those in mind, because those are things that I think are going to help you to understand some of the things that we're going to be talking about in today's lecture. So again, this is all on the biology of mood disorders, and it's a very important area in the field of behavioral neuroscience, in which I think we've been making some very significant strides in terms of understanding what forms of treatment, for example, are effective, which ones aren't, where they seem to be acting, and I think that these are all things that certainly are important for moving on for a more comprehensive understanding of the field of behavior disorders as it relates to behavioral neuroscience. So again, mood disorders, we'll be talking about depression, we'll be talking about bipolar disorder, what some also refer to as manic depression. And again, this is an area which has attracted a lot of attention from those in the field of behavioral neuroscience, especially those that are in the area of psychopharmacology. And again, some major strides have been made in that area with some of the what are called second and third generation drugs that have been now identified and have found to be more selective in terms of their impact upon physiology and with fewer side effects. So if we take a look then at some of the major issues in the study of depression, I think we can divide it up into two basic areas. One is, why do we consider depression to be the common cold of mental illness? And I think that will be revealed in some of the epidemiological work that's been done. And so we're going to take a look at that. It is indeed the common cold of mental illness when we take a look at the prevalence of this disorder. And secondly, we want to know about the factors that contribute to the development, the etiology of depression. What are the treatments that have been used to try to help those individuals who suffer from this disorder? And let me say at the outset that it's not so much that one type of treatment is more effective than another type of treatment. It's really what we're looking at is what we call combination treatments that have been found to be the most effective in terms of treating various aspects of depression. So let's again I try to put a face on this for you to try to help you to understand a little bit about how common this is, and all one needs to do is to take a look at certain figures in our history, like Vincent van Gogh, like Abraham Lincoln, for example, very famous American president. Van Gogh, very famous artist, both suffered mightily from depression, and indeed, in the case of Vincent van Gogh, he took his own life. The self-portrait that you see there, very famous self-portrait that he painted, and shortly after that committed suicide. If you take a look at other figures, for example, here's another individual who suffered greatly from depression, Philip Seymour Hoffman, very famous American actor, indeed won an Academy Award for his performance and other awards. He had periodic bouts of depression and ended up taking his own life. Robin Williams, another famous American actor, one of our great actors in terms of the awards that he received over the span of his very impressive career, who ultimately also suffered from depression and ended up taking his own life. Here's an individual that you're probably a little less familiar with from a few years back. His name is Andreas Lubitz. He was an airline pilot and suffered from depression, went off the medication that he was on, and piloted a commercial airline. And over the course of this flight, crashed the airline purposely into a mountaintop. I believe it was in Italy, and killed everyone that was in the aircraft, including himself. So again, these are, again, putting a face, I think, on depression is important before we begin to understand a little bit more about it. Here's another individual, Andrew Solomon, who has written very extensively about his own experiences with depression, and I think that he's featured in one of those videotapes that you watched, which I think is very revealing, and he discusses his own depression, and indeed wrote a book about it called The Noonday Demon, an atlas of depression, and was at the time was a remarkable piece of work, still is, and it is one that many often refer to in terms of trying to cope with their own depression. So some important facts about depression. A lot of the symptoms that you see of depression can result from a lot of different biological problems. Individuals who have imbalances in hormones, individuals perhaps who have a head injury, individuals who have brain tumors, other illnesses. You see a lot of the same kind of symptoms in these individuals, again, regardless of what the underlying biological substrate is that they're suffering from, that brings about the same kind of symptoms that you see in an individual that is diagnosed as being depressed. So it could have the etiology then of depression. It can come from a variety of different sources. And if you take a look at other behavior disorders, it's comorbid with schizophrenia, it's comorbid with certain types of substance abuse, it's comorbid with anxiety. You see individuals, for example, that are Parkinson's patients who also suffer from depression. And the real important symptom of this is the absence of happiness. That's the most reliable symptoms. It's not so much increased sadness that a person is experiencing, but rather it's this unhappiness that they experience, this chronic unhappiness that they experience. So to understand why we call this the common cold of mental illness, you have to understand the epidemiology of this disorder. And again, the statistics that I'm going to give to you are ones that were accumulated here in the United States, but this is something that's worldwide. And indeed, when you take a look at it worldwide, you tend to see very similar kinds of figures. For example, in the United States, it's the leading cause of disability between the ages of 15 and 44. It affects close to 15 million people a year. about 6.7% of the United States population in any given year between 15 and older. That's a huge figure. That's a large number of individuals every year that are suffering from this particular disorder. Major depressive disorder can develop really at any age. The median age is 32.5 years. It seems to be more prevalent in women than in men. And one of the real challenges in this area now is the diagnosis of individuals at a younger and younger age for depression and the problems that come about in terms of treatment, especially drug related treatments for young children. Very controversial area right now in the study of depression. Just a brief reference to the Diagnostic and Statistical Manual of Mental Disorders, the DSM, which is, we've been in the 5th revision of that now, because we're going to talk about some of the symptoms of this disorder that we call depression. I'm presuming that you've all had some background in what the DSM is, but for those of you who have not, just let me say that it is a descriptive document. It's not explanatory. It doesn't really depend on any particular theory. What we really know is that it's evidence-based. That is, it's really dependent upon research that has been done in terms of the various kinds of behavior disorders that are out there. So it's a classification then that's based upon scientific evidence. And it's really the latest research that has been done that has driven the revisions that have been made in the past. And I suspect there will probably be another revision over the next 2 or 3 years that will take the place of DSM-5. So a diagnosis then is based upon observable symptoms, and the DSM gives you direction in terms of how we would go about diagnosing any particular disorder. So it's based upon the number of symptoms, it's based upon how long lasting those symptoms are, and it's dependent upon the severity of those symptoms. So again, it's not anything that's explanatory. It is simply descriptive. And again, it's not based upon any particular theory. And again, it's research that drives this. It's evidence-based prior research that is dictating what we know about these various disorders, what the symptoms look like in terms of their number, their duration, and their severity. So again, we have this manual that we use in order to make a diagnosis. So what does the DSM actually say about depression? Well, major depression, feeling sad, feeling helpless, and it's for weeks at a time. It is not something that's acute. We all get depressed from time to time, but we quickly recover from it. It's when you have those feelings of sadness and helplessness really for a long period of time. And again, it's these feelings of hopelessness that are one of the primary symptoms of this disorder. These are individuals who don't have a lot of energy, they feel worthless, they have suicidal thoughts, difficulty in terms of sleeping, difficulty in terms of concentrating. They don't derive pleasure from a lot of things that people ordinarily derive pleasure from in their lives. But really, it's this feeling of hopelessness that I think is really crucial for you to understand as being the single most important symptom. And again, this is occurring over a long period of time. It's chronic. It's not something that comes and goes, but rather it is something that is very chronic in a person's life. So there are a number of triggers for depression that I think are important to at least give you a little bit of background in. Certainly stress. And stress, there are stresses in our lives that can be negative. There are those that actually are very pleasurable, that can be very positive. And one that I highlight for you here is getting married. I mean, there are many people who are going through what should be an incredibly happy time in their life that become depressed. I think that ordinarily we think of stressors deriving from very negative kinds of events like loss of someone that's close to you, or maybe a loss of a job, or starting a new job. But keep in mind there are positive events that can occur in our lives that also can result in depression. One of the triggers, important triggers that I think we should focus on a little bit is this whole idea of learned helplessness, where an individual essentially learns that nothing that they can do can make a difference in terms of encountering successfully a particular problem in their life. Now, this is a theory that was advanced on the basis of some animal work that was done a number of years ago by a psychologist at the University of Pennsylvania by the name of Martin Seligman. And it's probably the leading theory of depression today in terms of the etiology of depression. And essentially, individuals give up and they become helpless, they become hopeless. So again, that has been a very big advance in terms of our understanding of the etiology, the trigger for depression. So there are traumatic events that can occur in our lives, certainly that can be triggers for depression, a medical illness, maybe losing something in a disaster, a natural disaster, for example, that going through a traumatic time, like a pandemic, for example, the COVID virus pandemic. I mean, those are all potential environmental triggers for depression. Childhood difficulties certainly can be another source, trigger for depression, sexual or physical abuse. Being in a situation that's chaotic in terms of a young child, for example, during their early life, separation and divorce in a family, perhaps a mental illness or some kind of a medical illness on the part of a parent. These are all triggers for depression. You know, there are an array of different treatments for depression depending upon whether it's mild, moderate, or severe. But let me just enumerate a few of these things in the case of mild depression. I think there's the thought on the part of some in the mental health field that in terms of mild depression, we're just going to wait and see. We're going to work with that client, but for a lot of individuals, it is something that lifts over a period of time and goes away. Certainly, there are therapists also who believe very much in exercise. In the treatment of mild depression, there are self-help groups. But in terms of mild depression, there's this idea that before we start engaging in some kind of a biological treatment, meaning some kind of drugs, we're really going to pursue these other things first to see whether they might be helpful for this individual. And again, we're talking about individuals who are mildly depressed. Treatments for depression when we have moderate to severe depression, certainly antidepressant drugs, combination therapies in which we're using both antidepressant drugs as well as various forms of psychotherapy, various forms of talk therapy, and certainly entire mental health teams, for example, can be solicited to help individuals in terms of treatments for depression. When we certainly take a look at the case of severe depression, where we would be soliciting individuals who have expertise in a variety of different specialties. So again, these are all things I think to consider, as we go along in terms of trying to understand the underlying biology of this disorder and how to go about treating it. The neurochemistry of depression is something that has been investigated for quite a period of time. And as you know from some of the earlier lectures that we've had, there's many different neurotransmitters in the brain that have been identified. But the three that seem to be most implicated are serotonin, norepinephrine, and dopamine. And especially, would emphasize serotonin as being, a primary candidate, in which I think that we have the most information on now. And again, this visual that we have here in terms of, understanding what happens in terms of neurotransmitters when they're released out into this gap and then are taken up by specific receptors in this postsynaptic area, or they feed back upon this presynaptic area in terms of what we call reuptake. That's what scientists have concentrated on in terms of trying to understand the neurochemistry of depression. I mean, where it's really at is understanding what's going on here in this gap, the synaptic gap. So again, there's been a great deal of emphasis in drug research in the field of psychopharmacology in looking at drugs that have very specific effects upon neurotransmitter systems. So let's take a look at these. I have them grouped into four basic categories. The tricyclics, you see here the SSRIs, selective serotonin reuptake inhibitors, the monoamine oxidase inhibitors, and what are called atypical antidepressants. And what I want to emphasize about this is that you're really going from older drugs that were developed quite a while ago in terms of tricyclics to the SSRIs, to the monoamine oxidase inhibitors, to the atypical antidepressants. This progression that you see here is one that's evolved over a period of time. Older drugs, antidepressant drugs that you see here, and the more recent ones, what we call second, third, and fourth generation drugs that you see here. Typically what will happen is that when an individual is being treated with an antidepressant drugs, tricyclics will be initiated first, that we tried first, then SSRIs, then monoamine oxidase inhibitors, and then atypical antidepressants, kind of in that order. And it kind of goes in an order of specificity. With the more recent second, third, and fourth generation drugs, they have more specific effects upon neurotransmitter systems, and their side effects tend to be less. So keep that in mind as we go along in terms of trying to understand the various antidepressant drugs that have been used. So the tricyclic drugs, and again, a good example of that is a drug that's been around for quite a while. It's called imipramine. What it is doing is it's preventing the reabsorption of neurotransmitters like serotonin, for example. So it's preventing reabsorption taking place, coming back, reuptake. It's preventing that from happening. So what it's doing is then it's making more serotonin available for action at the postsynaptic area. So that is principally what is happening in terms of the tricyclic drugs that are being used to treat depression. SSRIs, on the other hand, this is really the next generation of drugs. They also block reuptake of serotonin, but they do so in a more targeted way. And they don't impact other neurotransmitter systems like dopamine, like norepinephrine, for example. The tricyclic drugs are not anywhere near as specific as the SSRIs in terms of blocking reuptake and not influencing other systems. Perhaps the most famous of these is Prozac, that is almost considered to be a wonder drug used for a lot of different purposes now, not just in the treatment of depression. But certainly Zoloft, Luvox, Celexa, and Paxil are all examples of drugs, antidepressant drugs, SSRIs, that have been developed by, by pharmaceutical companies. The monoamine oxidase inhibitor drugs, they block this enzyme that's called MAO. And MAO is involved in metabolizing the neurotransmitters catecholamine and serotonin. And what they do is they metabolize what monoamine oxidase does ordinarily is it metabolizes catecholamines and serotonin into their inactive forms. So again, when we're utilizing these inhibitor drugs, essentially what we're doing is we're making more of a particular drug available for action in that postsynaptic area. So again, this is I guess what you would call a third generation drug that has been used to treat depression. So blockage of the enzyme then is making a lot more of the transmitter available in the presynaptic terminal. So a lot more now is being made available for release. And again, typically what happens is that if SSRIs are not effective, if tricyclics are not effective, then what we would do is we would go to this next approach, which is that of monoamine oxidase inhibitor drugs. So atypical antidepressant drugs, a good example is one that's called Wellbutrin. It has very mild side effects, and that is why it is something that is highly preferred over the other classes of drugs that we're talking about. It inhibits the reuptake of dopamine, doesn't really seem to impact serotonin that much, modifies norepinephrine a little bit, but is principally working in terms of the reuptake of dopamine. How do antidepressant drugs work? Well, we don't really know. That's the message that I want to get across to you. It's very unclear. One of the things that we know about antidepressant drugs is when they are administered, they are acting really quickly in terms of modifying what is happening to the synaptic activity and neurotransmitters in the brain. But the effects in terms of lifting an individual from depression, that is not something that occurs rapidly. It is something that occurs maybe over a several week period of time. So you're getting biological effects of these antidepressants that are happening quickly upon their administration. They're altering synaptic activity, and hence they're changing the pattern of secretion of neurotransmitters. But in terms of their effects upon behavior, that doesn't appear until several weeks later. So that's always been a mystery, and has suggested to some that there must be other things that are involved. So depression probably is not solely due to a change in serotonin levels. It's probably not purely due to low serotonin levels. If it was purely due to that, then we would see effects of antidepressant drugs immediately upon behavior, but we don't. Indeed, if you were to take a look at the blood samples of serotonin in the brain, you would see completely normal levels oftentimes in depressed individuals. So that's why it's a mystery still in terms of what the actual etiology is in terms of underlying biology that is involved in depression. And again, that is something that has persisted for since we've been exploring the underlying biology of of depression.